video is about physiological changes in a pregnancy. What are the physiological changes in pregnancy, or what is the definition of physiological changes in pregnancy? It is remodeling of maternal systems, changing of maternal systems. Why? For two purposes, or two main purposes. The first one is to deliver energy and growth substances to fetus. So the maternal or the mother should deliver some of her energy and growth substances to the fetus. And the second one is to remove inappropriate heat and waste products. So the baby should deliver or should have some energy and growth substances and should get rid of inappropriate heat and waste products. So multi-systemic changes should happen to adapt for these changes. So these are the physiological changes in pregnancy. The overall purpose behind physiological changes in pregnancy is to support requirements of fetal growth and hemostasis. So fetal growth and hemostasis are the goals behind the physiological changes in pregnancy. And these changes should take into account no harming to the mother. So the support of requirement of the baby, the energy and the growth factors, and remove inappropriate heat and waste products should never be associated with deteriorating in maternal well-being. And here is the game. So let's start with the first system to be remodeled in pregnancy, the cardiovascular system. And actually the cardiovascular system changes are the most during the pregnancy. We have a change in cardiac output, in intravascular pressure also, and we have a change in mechanical circulatory effect of uterus on the veins, and we have change on regional blood flow distribution to different organs and murmurs. I'm going to talk about every one of them into detail, starting from the cardiac output. In a pregnancy, we have an increase in aldosterone level. We have an activation of renin-angiotensin-aldosterone pathway. The increase in aldosterone will lead to retention of sodium and fluids. Sodium retention will be about 500 to 900 milliequivalent. The retention of sodium and fluid will increase total body water. How much? About 6 to 8 liters of total body water. And about 2/3 of total body water will be extravascular. So this increase in total body water will increase total blood volume by about 40% increase in total blood volume. The increase in total blood volume includes a plasma volume increase and RBCs increase. The plasma volume increase is about 50%. We have about 50% increase in plasma volume, and this is in the period between 6th week and 32 week. At 32 week, we have a plateau of increase in plasma volume. After 32 week, we mainly have little or no increase in plasma volume. So how much plasma volume increase? About 50% in singleton. But in multiple pregnancies, like in twins and triplets and so on, there is even more increase in plasma volume, may reach the level of 70% increase. Whereas the RBCs increase will be no more than about 30%. Can you notice that we have 50% increase in plasma volume and only 30% increase in RBCs. So we have disproportion between these two values. This disproportion of these two values will decrease hematocrit, okay, and that will lead to what we call hemodilution, a lot of plasma with less than expected RBCs, okay. So this hemodilution will cause what we call physiological anemia in pregnancy. It is right that hematocrit will decrease in pregnancy. It will be low, but the good news here, it is optimal, okay. It is optimal. What do we mean by optimal? We mean by optimal that we have more than sufficient hemoglobin to carry out the oxygen, okay. So hemoglobin will be more than sufficient to carry the oxygen. So between 35 and 32 and 35 hematocrit is optimal, okay. Below 27 is not accepted, and above 39 is not accepted. So below 27 and above 39 are associated with poor outcome, okay. So this is the stream, but until now I didn't tell you how does the cardiac output increase. We said that we have increase in total body water due to retention of sodium and fluid, and as a result we have increase in total blood volume about 30%. The increase in total body volume will increase stroke volume, and this is the main factor to increase cardiac output. The cardiac output will increase of about 30 to 50% due to increase stroke volume. Is increase in stroke volume the only cause to increase cardiac output? No. Also increase heart rate will increase the cardiac output. How many cardiac heartbeat increase during pregnancy? We have an increasement of about 20 beat per minute, okay. So increase in both heart rate and stroke volume will lead to increased cardiac output. But what are the first responsible for increased cardiac output? It is stroke volume. The second is heart rate, okay. So cardiac output will increase about 30 to 50% in the period between the 10th week of pregnancy to 20 to 24 weeks, okay. So it will increase till the second trimester, and after that it will be in a plateau, almost in a plateau, okay. The cardiac output levels in exercise are more in a pregnancy, okay. So in our normal life, if we have an exercise, the cardiac output will increase, but in pregnancy it will increase much more, okay. So it will reach the maximum cardiac output at lower levels of exercise. So this is the first thing about the physiological changing in pregnancy, cardiovascular changing, the cardiac output. And I want to remind you that in pregnancy we need 1 gram of iron, or 0.7 to mom and 0.3 to the fetus. Now let's move to the other changes in cardiovascular system during pregnancy. The intravascular pressure. In a pregnancy, we have increase in steroids and vasodilators. Vasodilators like what? Like progesterone, like nitrous oxide. Okay, all these vasodilators will increase, and that will lead to decrease in arterial blood pressure due to decrease in the vascular systemic resistance. Okay, so we have decrease in arterial blood pressure, systolic and diastolic. The diastolic decrease is more than the systolic decrease, okay. We have a decrease of about 5 to 10 millimeter mercury in systolic blood pressure, but in diastolic blood pressure it is about 10 to 15. Okay, 10 to 15. So when does this decrease happen? It happens in the first trimester until we reach the mid-pregnancy. In the mid-pregnancy of about 24 to 28 weeks, we reach the lowest blood pressure. Then, till term, from the period of 24 to 28 weeks till term, we have a mild increase in blood pressure, okay? Modest increase of blood pressure until we reach the baseline. We should never exceed the baseline of pregnancy. If we exceed the baseline blood pressure of pregnancy, then we have hypertension disorders in a pregnancy. Okay, this is about the arterial blood pressure. It will decrease in a pregnancy. What about the venous blood pressure? Venous blood pressure, we have the central venous blood pressure, which will be unchanged, okay, and we have femoral venous pressure, which will be increased, okay, 2 to 3 times, mostly at the 30 weeks gestation. And the reason behind the increase in femoral blood pressure, femoral venous blood pressure, is due to compression of the uterus on the veins of the pelvis, okay, on the iliac veins, abdominal aorta, inferior vena cava. I'll talk about this in details in minutes, okay. So the blood pressure will be at its least value at left lateral position, okay. So if we rest in left lateral position, then the blood pressure will be at lowest values, okay. So these are the changes in intravascular pressure. We talked about cardiac output, intravascular pressure, and now let's move to the third thing, the mechanical circulatory effect of the gravid uterus. As you know, in a pregnancy the uterus is enlarging, and the enlargement of the uterus will compress various abdominal structures, like what? Like iliac veins, like abdominal aorta, like inferior vena cava, and of course other structures like bladder and so on. But here we are talking about the vasculature. So the pressure on the iliac vein, abdominal aorta, and inferior vena cava will lead to marked hypotensive effect, okay. So we'll have hypotension due to this pressure, okay, especially in supine position. Why? Because when the pregnant woman rests in supine position, there will be a pressure applied to the inferior vena cava, abdominal aorta, and iliac veins, and that will lead to decreased return of cardiac output to the circulation and decrease in blood pressure. Okay, so we have fall in venous return due to the pressure applied to these veins. The fall in venous return will decrease cardiac output. The decrease of cardiac output will mostly be compensated by increased vascular resistance. So we have a decrease in cardiac output. What the vessels are going to do, they are going to compress themselves. We are going to restrict, okay, and vasoconstrict, and that will lead to a compensation. This will happen in most of cases, but in 10% of cases there will be no compensation. In the cases of no compensation, we will have what we call supine hypotension syndrome. The vessels are not able to constrict, and there will be increase in blood pressure. In supine hypotension syndrome, we have symptoms like nausea, vomiting, and syncope, and we can relieve that by changing the position from supine to left lateral, for example, or to sitting position. So, is the decrease in cardiac output the only event that happened due to fall in venous return? No. Also, fall in venous return will elevate pressure in veins that drain the leg and pelvic organ, and elevated pressure in these veins will lead to varicose vein exacerbation and hemorrhoids. Okay, so we have less venous return, so we have more accumulation of fluid, we have varicose vein exacerbation, we have hemorrhoids, and we have edema. This is the most important. Physiological edema in pregnancy is due to the uterus pressure on the veins that drains the lower extremities. Okay, so we have no drains of the lower extremities, we have edema. Also hypoalbuminemia status, which will lead to decrease on oncotic pressure and distribution of fluid from the intravascular to extravascular space will lead to edema. But the most common cause of edema is the elevated pressure in veins that drains leg and pelvis. Okay, this is about the mechanical circulatory effect of the uterus. What about the regional blood flow distribution? In a pregnancy, the regional blood flow distribution will increase, okay, to most of organs. And this will happen in early pregnancy, except of some organs like breast, skin, kidney, and uterus. The increase in blood distribution to this organ will not stop in early pregnancy. It will continue to term, till term, okay? So, increase in blood flow to skin and kidney will lead to waste product and heat get ridden. We can get rid of these products, of waste products, by increase the blood flow to these organs. And increase the blood flow to kidney will lead to a lot of creatinine clearance. And that's why we have a mild decrease in creatinine in a pregnancy. Okay? So, skin and kidney get rid of waste product by increased blood flow, explains why we have more plasma, okay, than more plasma increase than RBCs. The disproportion that we talked about, okay. So more plasma is needed to get rid of the waste products than RBCs. Okay, that's why we have disproportion between the plasma and the RBC. The increased blood flow to uterus is very marked. Okay, it is about 1,200 ml per minute. Okay, from just 200 ml per minute in pre-pregnancy status. This is about the distribution of blood flow in pregnancy. What about murmurs? Only systolic ejection murmurs are acceptable in pregnancy, and the systolic ejection murmurs in pregnancy is due to increase in cardiac output in pulmonary and aortic flow. Okay, so this is the cause behind this. Okay, in the next video we are going to talk about the other physiological changes in pregnancy, like in pulmonary system and other system. Thank you very much for watching.